Oncology and Executive Medical Director of Swedish Radiosurgery Center in Seattle, Washington. He attended the Johns Hopkins University School of Medicine and completed his residency training at the University of Washington Seattle Cancer Care Alliance. He specializes in the treatment of complex cancers, including brain and spine metastasis. We are honored to have Dr. Loisel moderate today. Welcome, Dr. Loisel.
Thanks so much, Joanne. It's a pleasure to be here today. I have the pleasure of introducing first Dr. Peter Belusic. Dr. Belusic is a neurosurgeon who attended the University of Michigan Medical School and then pursued neurosurgical residency and fellowship at UC Irvine. Dr. Belusic is a neurosurgeon specializing in general and endovascular neurosurgery and radiosurgery. His interests include treatment of cerebral aneurysms, arteriovenous malformations, essential tremor, cerebrovascular disease, and tumors by both open surgery and radiosurgery. When he's not working, Dr. Belusic is often found traveling the high seas as an avid sailor. And I must say that Peter is just a great doctor, and it is really an honor to work with him. Sophia Loisel is a student research associate interested in medical economics and neuroengineering. When Sophia is not working or attending school, she is an avid lacrosse player and enjoys skiing, reading, and hiking. Our first speaker today will be Dr. Peter Belusic, giving us a general overview of essential tremor as a condition and the indication for various potential treatments.
Great. Thanks, Chris. Let me see. There we go. So thanks to the Radiosurgical Society for the opportunity to give a little talk about essential tremor and some of the work that we've been doing at Swedish Radiosurgery Center to hopefully make patients' lives better. As many people know, essential tremor is an extremely common condition. More than 1 million Americans are suffering from it. And the prevalence goes up as the population ages, up to 20% incidence rate in the 90 and above age group. And it affects men and women equally. The clinical symptoms of essential tremor essentially is an action tremor as opposed to Parkinson's disease, which is of essential tremor. We do motor system when you're actually using your arms and hands. It affects the hands almost exclusively or almost universally, but also there are cases where the head, voice, and other body parts become affected by tremor. Half of all essential tremor cases are inherited, familial, as an autosomal dominant condition. But a lot of families know that it doesn't affect everyone in the family, and it can actually skip generations as well. So the penetrance is variable. And we sometimes see patients who will tell us that the onset of their tremor was, in high school or even in grade school sometimes. So it can be quite early onset. As I said, a fairly large proportion of tremor patients have the disease or the condition as a result of a genetic inheritance, and these are the linkages that have been found with essential tremor, and seems to be a link to a GABA receptor mutation, which may have implications in the motor system. There is also an environmental component, and probably the people with genetic predisposition also have to have a second a hit to their system to get the tremor. That may be why the variable penetrance. But there's a compound called harmaline or harmane, which is a neurotoxin that is found in meat products. It has been noted that people who eat meat have a higher incidence of essential tremor. And we can also see this compound in Parkinson's disease as well as cancer patients. And in fact, the rat model of essential tremor is created by applying this compound harmaline or harmane to the inferior olivary nucleus of rats to study the disease. And it's also been linked to lead exposure as well. So when we talk about the pathophysiology of tremor, what's actually going on, the defect is really in the cerebellum, and there is a feedback loop that becomes affected, a feedback loop of the motor system, such that you end up getting opposing muscle neurons firing alternately. Normally these are kept in check from each other, but the Purkinje cell defect in the cerebellum seems to be the root cause. And given the way that the cerebellum connects to the motor system, there's a choke point in the ventrolateral nucleus of the thalamus, where there's a relay of cerebellothalamic fibers coming up through the rubrospinal tract or dentorubrospinal tract, or called DRT, that then go up to cortical neurons, and then the signals go down to the muscles. So the ventrolateral nucleus of the thalamus seems to be a good point to target our treatment from a surgical standpoint. Of course, there are medical treatments that probably target other sites in the motor pathway. The ventrolateral nucleus of the thalamus is actually composed of two separate nuclei. The anterior part is called the VLA, or the ventral oral nucleus, and it relays motor fibers from the basal ganglia up to the supplementary motor area, which is probably why lesions that are too anterior don't actually affect the motor system per se, because the supplementary motor area is somewhat bypassable in terms of the brain getting motor signals down to the muscles. So we're actually targeting what's called the ventral intermediate nucleus, or the posterior part of the thalamus, which is where the cerebellar fibers relay up to the primary motor cortex. And that's a big distinction between the supplementary and the primary motor areas. So we target VIM. When we look at essential tremor, we're talking about an action or postural tremor. Again, sometimes or oftentimes a resting tremor as well. It's usually in the 4 to 12 hertz range. Almost all patients describe being affected by their hands initially, or in their hands initially, and certainly it gets worse as time goes on, and can start to affect other parts of the body. We do occasionally see patients who have a little tinge of Parkinsonian features to their essential tremor, such as a little rigidity, or like I said, resting tremor. Along with that, potentially impairment of gait and balance as part of their essential tremor picture. Any type of stress or adrenaline, such as exercise or anxiety, also caffeine, can make the tremor more prominent. And as I usually ask most patients, just as a sign of this actually being essential tremor rather than something else, essential tremor is often suppressed by consumption of alcohol, and the effect is temporary. So a lot of people become aware of this, through their social life, and it's also it's a good sign that what we're dealing with is actually essential tremor, and not something else. So when we rate tremor, we do a series of clinical tests, including handwriting and drawing samples. On the left, you can see a spiral diagram of someone without tremor, and on the right is a patient who is relatively severely affected by tremor and can't perform a smooth spiral. And this one would be graded as probably a grade 4, potentially not the most severe grade 4, but it has all the loops that you see, which would get it into the grade 4 category. So this is an objective way of grading the tremor. There's also a lot of subjective things that we look for, and mostly has to do with activities of daily living. As the tremor progresses, all of these things become more and more difficult and eventually just impossible, and people have a very hard time taking care of their own personal needs. And it can be very frustrating when you can't hold a newspaper steady to read it, or type on your keyboard, or a touch screen. So all of these things become quite problematic as tremor progresses. So we're obviously talking about thalamotomy today. Of course, the mainstay of treatment for mild to moderate tremor is mostly medical, including propranolol and primidone. There is also surgical treatment, including deep brain stimulation, as well as radiofrequency thalamotomy, which is not really practiced so much anymore. Focused ultrasound therapy was approved, I think it was in 2016 by the FDA. So it's been around 8 or 9 years. If you include the trial, more than 10 years probably. But we're here talking about gamma knife thalamotomy today, which has been practiced for several decades, actually. When we're targeting the thalamus, again, we're looking at the ventrolateral nuclei, and in particular the ventrolateral posterior or ventral intermediate nucleus, which is just about halfway between the anterior and posterior aspects of the thalamus, or the thalamus. When we do gamma knife thalamotomy, we're always treating people in the frame. We don't do mask-based treatment, at least not yet. A frame allows much better immobilization, and I think higher accuracy. And really, we're looking for sub-millimeter accuracy when we do functional neurosurgery with ablative procedures that are, once you do it, you can't undo it. So we do want to be very accurate. We mostly use the T1 weighted axial scan, either on a 1.5 or a 3.0 Tesla. And we do like the higher magnetic field strength because you get better imaging. Although for patients that aren't able to be scanned on a 3 Tesla magnet, you can use the 1.5 Tesla platforms. Sometimes we use proton density, also sometimes tractography, as I mentioned before, the dentro-rubro-thalamic tract. And then we can also see the internal capsule and make sure that our lesion is not extending outside the bounds of the thalamus. The whole technique for tremor thalamotomy or gamma thalamotomy is based on measurement of the distance between the anterior and posterior commissure. And once you define the midpoint of that line, then the targets are generally, the VIM is generally 4.5 millimeters above that plane, between 11 and 16 or so millimeters lateral, sometimes more if the ventricles are enlarged. And in general, about 4 to 5 millimeters posterior, although sometimes a little bit outside that range as well. And of course, the target coordinate has to be adjusted individually for each patient. And Sophia will be giving us a presentation in a few minutes about a way for making that a bit more accurate, involving a thalamic atlas, a deformable thalamic atlas. We use a 4 millimeter collimator isocenter. Sometimes we do sector blocking if we need to limit the radiation dose rate or change the orientation of the volume axis so that it's more parallel with the internal capsule, and you can kind of pull the dose away from the medial margin of the internal capsule that way. And our dose is generally 135 gray to the 100%. We have to note that most radiosurgery is prescribed at 50% isodose, so functional radiosurgery we're always prescribing to the 100% isodose. That's a big distinction. Here is a slide from the Schaltenbrand Atlas that shows you the anterior and posterior commissures. And then, of course, the thalamus is off sort of posterolateral to these structures. So we're measuring at the midpoint, and then all of the targeting for the VIM is based off of that. You'll see this again in a few minutes, but this is a coronal view at the level of the VIM nucleus. We have internal and external VIM nuclei here, and this is our target for the thalamotomy. The ventricle would be over on this side medially, and the internal capsule, of course, is this structure here. I hope you can see the arrow. Here's an actual screenshot of the gamma plan when we're doing a thalamotomy. You can't see the anterior posterior commissure because we're up at the level of the lesion, not at the ACPC plane itself. But if we were down here, you would be able to see the anterior and posterior commissure. So this is 4.5 above, and here's a shot with a 4 millimeter collimator that has a couple of blocks so that you can see that it's compressed in this direction and elongated a little bit in this direction, and that allows you to be a little bit more lateral with your target center and not extending out into the internal capsule. And then you get, of course, the coronal, and if we were over a little bit lateral, we would see the shot in the sagittal plane as well. But that's about where it lands in relation to the midline structures. Here's a patient who's being treated for their second side. This is the thalamotomy lesion that you see on follow-up MRI imaging. Here's the internal capsule right up to the edge of the thalamus here. And we're planning to treat the opposite VIM nucleus, but this is what we see with a good response to the treatment on follow-up imaging. This is at least a year later, if not longer. And once again, just to show you that here's the thalamus, and our lesion is tucked down right in this little corner here, right on the edge of the inferior infralateral VPM or VIM nucleus. So gamma knife thalamotomy has been done for a long time. The most retrospective analyses of the treatment have reported about an 80% likelihood of a good or excellent response, and this occurs over about 2 to 6 months following the actual procedure. So for the first couple of months, we don't really see any change, and then I tell patients that they're going to start noticing just very gradually that their tremor seems to be improving over the next 4 to 5 months. We don't get very many patients who keep responding beyond that time frame. So the radiosurgical lesion really matures at about 6 months or so. Given that it's non-invasive, there really aren't any medical contraindications or age restrictions to gamma knife thalamotomy. We've treated patients well into their 90s, and we can even, make accommodations, like I said, for people with pacemakers who can be scanned on a lower field strength magnet. In general, all of the or most of the retrospective studies report about an 8% or so risk of side effects, half of which are permanent, and then about a quarter of which, or a little less, can be severe. The most common things would be numbness or weakness, mostly numbness, but it can get severe and cause trouble with balance and gait, as well as hypophonia or other speech impairment. And it's important to note that the timeline for the side effects appearing is after the initial improvement, so that generally within about 6 to 12 months, if you're going to get something else besides the desired effect, it's going to be within the first 12 months after gamma knife treatment. When we look at the natural history of a radiosurgical lesion, this kind of explains how these variable responses occur. When you give 130 gray, 135 gray, initially there isn't any lesion, and then over time, the very center of that lesion, you get necrosis, and it starts to progress or get larger out from the center, out to a certain distance, and then the lesion stops progressing. But you get, say a 5 or 6 millimeter diameter area of tissue loss, and that's what we would consider basically a normal or good response. People who don't respond well to gamma knife probably have this scenario, or seem to have this scenario, where they may get just too small of a lesion, the radio resistant for some reason, and they just don't have enough loss of those neurons in the VIM to reduce the amplitude of the tremor sufficiently to make a clinical difference. And then when we see complications, in most situations, it's because of a patient-specific problem and not necessarily targeting error, but patients who are overly sensitive to the radiation end up with a larger lesion that then spills over into other nuclei or into the internal capsule, and you get neurological deficits related to those other structures. And unfortunately, there's no way to predict who's going to respond normally or under or over response. And so you just sort of have to do the procedure and hope and see what happens next. But fortunately, the vast majority of patients do have a good response. So here's a good example of someone who can't even, their tremor's so bad they can't even keep the pen on the paper to draw a spiral. And a year after their gamma knife thalamotomy, they basically have a normal ability to draw and to write. We don't have a writing sample here, obviously, but they had a very good response. So in 2014, we started a prospective registry of patients. And over the next 4 years, we enrolled 203 patients and did a total of 206 thalamotomies. And at this point, there are 169 patients with 1-year follow-up and 113 with 2-year follow-up. And so far, what we've seen is about a 77 to 78% improvement in writing and 71% improvement in drawing scores of more than 1 point, 1 point or greater improvement in the scores. These are the numbers for side effects, relatively low, in line with previously reported retrospective studies in the same range, total of about 9 to 12% at 2 years. So, so that's, I think, what I had to present, and I think we'll turn over to Sophia now to present her analysis of this patient population after their treatment.
Thank you, Dr. Belusic. My name is Sophia Loisel, and I am going to be discussing how we can improve target delineation in radiosurgical thalamotomy for essential tremor. So as we've heard, the traditional approach to stereotactic radiosurgical thalamotomy is to make a lesion based on stereotactic coordinates informed by a rigid atlas, such as the Schulten-Braun atlas, as shown here. And the clinical question I was looking to answer was whether using a deformable atlas could potentially inform better targeting. To further discuss traditional targeting methods, on the left we have a coronal left basal ganglia image from the Schulten-Braun atlas, and it's 5 millimeters posterior from the mid-commissural plane. On the right we have a T2 coronal image, and this shows a target based on the Schulten-Braun atlas with the CSF being bright, and this just demonstrates a thalamotomy defect in VIM. And the target on the slide on the right looks perfect according to atlas-based coordinates. However, it won't necessarily occur that way for every patient. As we heard from Dr. Belusic, only about 80% of patients respond to thalamotomy treatment, which is why I'm looking to improve the percentage of patients with an excellent response to thalamotomy treatment. So the main question when we're setting the target for a thalamotomy is the anterior to posterior targeting axis. The traditional coordinates from the mid-commissural point are 4.5 millimeters superior laterally to the edge of the internal capsule, and then 2 to 6 millimeters posterior, but this anterior to posterior direction anatomically has the most variability. On this slide here, we have images from the Brainlab Deformable Atlas, and we have coronal and axial views. On the left is a coronal view, and we can see the location of VIM outlined in pink on the right. And the location of VIM, as shown on this deformable atlas, corresponds to the Schulten-Braun atlas. It's very lateral. The VIM is very lateral in the thalamus, and it's elongated. It's an elongated target in the inferior superior dimensions. And then on the left, we have the axial view, and we can see that the VIM nucleus is very compact in the anterior to posterior directions. Again, it's highlighted here in pink. And we can also see how in green and yellow, the sensory nuclei are directly posterior. So this just brings a challenge when performing radiosurgical procedures because the target in the axial plane, anterior to posterior, is first of all very small, and we have concerns about the sensory nuclei being directly posterior as well. To further discuss the need for accuracy, the internal capsule is immediately lateral to the target, and hitting that can affect motor functionally. The sensory nuclei, such as VPM and VPL, are immediately posterior to the VIM target, so targets too posterior are at a high risk for sensory complications. And third, motor nuclei more anterior to VIM yield less benefit for tremor modulation, or in other words, targets that are located too anterior often lack treatment effectiveness. So the aim of the study we conducted was to determine if a deformable atlas can more accurately inform VIM targeting. Our methods were to assess Brainlab's tissue class deformable basal ganglia 7 Tesla atlas in the context of the prior prospective gamma knife thalamotomy study that Dr. Belusic mentioned. For both responders and non-responders, I compared the location of the delivered dose to the location of the VIM center suggested by Brainlab. To further discuss the prospective study, it was a blinded review of writing and drawing samples by a movement disorder neurologist with a 3-year follow-up after gamma knife thalamotomy, and there were 203 patients enrolled. So we reviewed the prospective results retrospectively to see if the Brainlab Atlas tended to agree with the target location in responders, and to see if the Brainlab Atlas would suggest additional alternative shifts to the targeting in non-responders. 78% of the patients enrolled in this prospective study had improvement in their tremor on the after gamma knife treatment. And out of those patients in the prospective study, 160 of them were evaluable for Brainlab analysis. Our hypothesis was that there would be a higher level of target agreement between the Brainlab target and the target used for treatment in patients who responded to treatment, and a higher percentage of target refinement suggested for patients who did not respond to treatment. So for our results, first of all, Brainlab suggested target shifts of greater than 1 millimeter in the anterior to posterior direction we considered to be significant, whereas shifts less than or equal to 1 millimeter suggested by Brainlab were considered to be target agreement. And this is because gamma knife overall accuracy goes to about 1 millimeter. So we saw about 83% of target agreement among responders. So that means for 83% of patients who responded to the treatment, the target that was used in treatment agreed with the target that Brainlab retrospectively suggested. And in contrast, for under-responders or non-responders, we only saw 64% target agreement between the target that was used in treatment and the target that was suggested by Brainlab. So when looking at our data, the Fisher's exact test suggests that the proportionality difference was statistically significant, with the p-value being less than 0.05. So finally, for some conclusions, in our retrospective analysis of prospective VIM thalamotomy targets with Brainlab, we observed high levels of target agreement among responders, and a higher frequency of suggested shifts greater than 1 millimeter in under-responders. Finally, for some questions for further study. First of all, it's the validity of suggested shifts in some responders, or in other words, how do we account for the small but significant number of people who responded to treatment, but BrainLab still suggested a significant shift in targeting? Next, what are the limits of BrainLab software for predicting VIM location? What are the assumptions that need to be validated in order for BrainLab to perform reliably? Finally, it would be interesting to explore the role of fiber tracking in treatment due to the fact that BrainLab and other vendors have software packages to evaluate fiber tracking. And perhaps the best VIM localization is a combination of fiber tracking and the use of a deformable atlas such as BrainLab's together. That's all. Thank you.
Peter, Sophia, thanks so much for the summary and some suggestions for how we can, apply the deformable atlas and maybe, employ more fiber tracking with our targeting. There are a number of questions here that we have some time to go through. The first one is, can you watch this again? And the answer is yes, it's recorded and will be on the RSS website. Thank you. Peter, maybe you can comment on this. This question is, what is the difference of target in essential tremor and Parkinson's disease? And I can give you my standpoint on this. If you're treating tremor, predominant Parkinson's disease or essential tremor, the best target is VIM. But if you are looking at the overall impact of Parkinson's on a patient and looking to try to improve things like increasing mobility versus rigidity, helping individuals with their gait and their speech, I don't think VIM is the best target. Peter, can you comment on that?
Yeah, if I have that slide back up that'll explain the difference. Certainly, with patients who have tremor-dominant Parkinson's disease, and perhaps not so much rigidity, the same target in the thalamus, the VIM nucleus, is targeted to control their tremor. If we're doing some sort of neurosurgical intervention. For patients with rigidity and the on-off phenomena with their medications, whose ADLs are mostly limited by those symptoms, the subthalamic nucleus down here, which would be sort of more in this area, is the target for deep brain stimulation. So the electrode gets passed all the way through the thalamus and into the subthalamic nucleus to treat those on-off symptoms, the rigidity, the bradykinesia. So that would be the main difference between treating tremor and Parkinson's, essential tremor and Parkinson's disease from a neurosurgical standpoint.
Thank you. Yeah, there was a comment about the audio. We did have some audio lag here too. I don't think that was on our side. I don't know what the issue was. It seems to be okay now. I hope it's okay for you as well. The next question is a very interesting one. It is, tell us your experience of head nodding after Gamma knife thalamotomy. And I'll start, and Peter, I welcome you to chime in as we've treated a number of these patients. We'll often see that when we treat a patient, let's say, who's right-hand dominant with a left thalamotomy, that we generally don't see much in terms of left-handed symptom improvement, right? So we don't see much same side improvement. We see improvement in terms of contralateral function, this being sort of higher level circuitry. But in terms of axial symptoms, if you treat the dominant side, there's about a 50% chance that axial symptoms, head nodding, jaw tremor, voice tremor, neck tremor will improve. We have treated some patients. Gosh, there's a woman from Alaska who I will never forget, who had the most severe head tremor that I've ever seen. And we treated her left VIM to try to start with improvement in her right-sided symptoms, and her head tremor completely ceased. And she had among the worst head tremors that I've ever seen. But I wouldn't plan on that. I wouldn't expect that. I think that in our series of treating in a staged fashion bilateral thalamotomy, that we'll see about an 80% chance of improvement in central or axial tremor. Peter, would you agree with that? Any additional thoughts?
Yeah, I think that 70 to 80% likelihood after both sides are treated. I think I've seen head tremor improvement in 1 or 2 patients with a unilateral thalamotomy. I think the way to think about it is that, you know, with the thalamotomy, you're treating one side and you get improvement in the extremity function on the opposite side, but the tremor of the head and neck and voice is more of an axial tremor rather than a extremity tremor, and it probably depends more on bilateral innervation. You know, because both sides are getting activated when you are using those parts of the body, or when they're being you know, stimulated. So the central or axial tremor doesn't seem to respond as well to a unilateral thalamotomy, and you really don't see much improvement until you've treated the other side as well. It just seems that there's a little bit lower chance of actual response of the axial tremor, even with the second side being treated, than either hand tremor. So we get about 80% chance, or around 80% likelihood of reduction or elimination of the hand tremor with either side being treated, but a little bit less with the head and the voice, the sort of the midline or axial tremor.
Next question is, are there Medicare reimbursement codes for functional SRS? And the answer is yes. Just like radiosurgery for malignant conditions, benign conditions, the codes are the same. For example, essential tremor ICD-10 G25.0 is a standard indication of, you know, all Medicare intermediaries and private insurers. So yes, the reimbursement is there. Ted, good morning. Your question is, how does SRS compare with other ablative treatments for thalamotomy? Your question is, if similar or better, why isn't there more tremor patients being treated with SRS? I think that one of the reasons in terms of users that there aren't more patients being treated with SRS is that 135 Gray is a very high radiation dose, and it is a treatment that it's an elective procedure that has a significant, arguably small, but significant risk of potentially life-altering side effects. And I think that what Sophia was getting to with the ambiguity in the target, especially in the anterior to posterior plane, I think that it is difficult to generalize this therapy to all centers at this time. But I think that with a knowledge of Atlas-based targeting, as in, you know, the traditional understanding of application of rigid Atlas, I think that the use of deformable Atlas and fiber tracking altogether, that will eventually unite around more standard operating procedures and approaches that I think can be generalized. You know, I went to a talk of Lozano from Toronto not long ago, and he said that in answer to your question of how does SRS compare, I will quote him and I will say, he said, and I liked this generalization, he said, the outcomes with Gamma Knife, DBS, and focused ultrasound are all the same. It just depends on, you know, what you and the patient want to do. And I think that, you know, the effectiveness of all of these treatments is relatively high. I think everything comes with trade-offs and certain risks for side effects. And I think that one very nice thing about SRS, as Peter mentioned, we could pretty much treat everybody. You know, there's only one patient that I've seen in 13 years that had, you know, highly unusual thalamic anatomy from arterial ectasia, where we said, you're just not a candidate for this procedure, just one. But everybody else, irrespective of medical comorbidity or other concerns, if they meet the clinical criteria, are likely a candidate. Peter, can you comment on any other contrast of SRS versus other ablative procedures like focused ultrasound?
Sure. I mean, I'm not a practitioner of the focused ultrasound or DBS personally, but my mentor, Ron Young, who, you know, was really a pioneer in, you know, radiosurgical thalamidomy, you know, his feeling, and I think this rings true, is that, you know, the target is the same, essentially, when you're dealing with tremor. And so it's not illogical to expect or suppose that, you know, however you eliminate the signals passing through the VIM nucleus, you're probably going to get about the same response rate. So surgery, DBS, you know, even radiofrequency back in the day, focused ultrasound, which is sort of the updated radiofrequency technique, I suppose, for how it works in an event. You know, the vast majority of patients, that is the choke point, and you know, you're going to get similar responses. I think complications and side effects tend to differ a little bit between the modalities, and that's sort of the one of the reasons why radiosurgery is probably able to treat almost anybody rather than DBS or focused ultrasound. Certainly with the ultrasound therapy, there is a skull density limit that above which you just aren't going to get a lesion or an effective treatment. But we don't have that in radiosurgery. We just compensate for the density of the skull with the dose calculation. You know, I think that all of these modalities have their, you know, pros and cons, their benefits and their risks, and it is sort of a patient and physician specific kind of discussion about, you know, what you're willing to tolerate in terms of risk and or side effects, really.
Yeah, you know, and then I think it's great to have all options. I think that there are some patients who are particularly maybe suited for one modality over the other. In terms of
patients really are candidates for any of the three, right? I mean, there's many patients that we see could have focused ultrasound or DBS. The a lot of patients, I think, like Gamma Knife because of the non-invasiveness. And you don't have to, you don't have to lose your hair for the part of the procedure, but, hair grows back. So,
in terms of managing complications, I think that it's really important to realize that complications are a reality with thalamotomy in a small number of patients. And I think that every program that is doing this needs to be A, aware of this, and B, have a team of people who can manage complications. And for example, in over-responders that have manifestations of late radionecrosis, our neuro-oncology team gives these patients bevacizumab. And I think that you have to have this ready to go. You have to have somebody who will give bevacizumab as a treatment for late radionecrosis from functional stereotactic radiosurgery. And, I've seen publications where there are listed 0 complications from this procedure. And I think that those programs lack follow-up because complications occur late. And you have to be ready for this. You have to be caring for these patients long-term. How do you level the patient's head? We use the Lexel, I think it's referred to as the G-frame. And we have a leveling box in MRI. Oh, no, I'm sorry. We do that in CT. How do we level the patient's head during MRI? Will this be important to target in the treatment planning system? We level the head in CT, and then we do kind of a rigid fusion between the MR and CT. So leveling the head during MR hasn't been an issue.
In the Gamma plan, as you're doing the targeting, there is a specific button once you define AC and PC that will orient the three-dimensional, the volume based MRI to that plane, right? So it doesn't have to be leveled on the MRI because the software takes the volume acquisition and can rotate that so that it is aligned with the ACPC plane.
Yeah, I think that, as long as you're able to rotate your MR, like Peter's saying, to be coplanar with ACPC, that's the trick, really. A lot of questions about focused ultrasound. I think that, focused ultrasound is popular. There's just so much marketing for ultrasound. Insightec or others have these fairly robust commercial central referral networks that have been set up. Again, it's a different treatment. I mean, a patient has to lay in an MR for hours. They have to have their head shaved. They have to meet skull thickness criteria. There are some, gait instability issues that we've seen with some patients that we don't have with Gamma Knife. So we could do a talk. The next, Joanne, Carrie, the next talk is going to be focused ultrasound versus Gamma Knife thalamotomy for treatment of essential tremor. Do we use the Atlas mapping result in our planning now? Not really. We've been working with BrainLab to kind of look at this and do some validation things. I think that, we've mostly relied on MR delineation and to some extent fiber tracking. We've struggled a little bit with some variability in fiber tracking depending on how the tracks are seeded. The next question ties into that. Would the use of a 7 Tesla MR in planning help in targeting? I think so. I mean, the 7T images that I've seen are phenomenal, but we don't have a 7 Tesla MR. Dan, I appreciate the question. If you have one and we could scan our patients, let us know. We should talk to GE and Siemens too. Do you repeat the procedure after, will we do a second round? We have not done a second Gamma knife thalamotomy, but we have done procedures after failed focused ultrasound. We have done it after failed DBS. We've done it after failed DBS with lead out and lead in. We have done, this is less exciting, but we've done contralateral procedures with Gamma knife after focused ultrasound or after DBS. But we have not redone a radiosurgical lesion. There's actually one other patient too, I think, that where we had concerns where the patient had huge lacunar strokes in the thalamus, and I think that we waived on that patient too. So there was one patient who had very abnormal thalamic anatomy due to vascular ectasia, and then another who had thalamic strokes that we were a little bit worried about rocking the boat. How do we request CME? I'll ask you to follow up with RSS by email, or maybe they could address that question at the end. How accurate is functional MRI versus Brainlab Atlas contouring? Well, you know, fMRI, Peter, you know, help me here too, but we don't really use fMRI for delineation of targets because, you know, there's like no specific actionable motor or, you know, voice function that you can kind of trigger, you know, that functional delineation. So we don't use fMRI in identification of basal ganglion nuclei that are targets for functional. Can you please compare Gamma knife and CyberKnife? I certainly can. I'm sitting, you know, about 10 feet from CyberKnife and about 30 feet from the Gamma knife right at this moment. But this is going to be another talk. Joanne and Carrie, comparison of Gamma knife, CyberKnife, and linear accelerator-based stereotactic radiosurgery for the treatment of benign and malignant and functional conditions. Listen, that, you know, the next question is, you know, LINAC-based SRS. The thing is that the complications related to radiosurgical thalamotomy are a late event. You have to follow these patients for a while. We actually have 3-year data on this 200 patient series now that has matured. And as our follow-up was accruing, we had one really late side effect at like almost 2 years. And it was something that was very unusual for us. And then we kind of held on to publication of the 2-year results until we really had the 3-year results mostly, because we were worried that we might accrue more late severe side effects. And look, you have to do the work. We have to treat the patients on study. And we have to, you know, you have to do stuff like this. You have to treat 200 patients with LINAC-based and then report 3-year follow-up. Because the side effects are fortunately not very common, but I think that they're kind of generated by the when the targets are, you know, executed well. I think that they're a function of the 20 gray and 30 gray regions. And so, you know, if you look at, for example, the AVM literature, you're looking at V12 to predict symptomatic radiation necrosis. The V12 with certain LINAC plans can be enormous, whereas it tends to be extremely compact with Gamma knife and CyberKnife. So, you know, just more work needs to be done. I think it's all possible, but, you know, how that 30 gray line, that 20 gray line, that 12 gray line looks with 3-year follow-up is important. In the future, LINAC-based SRS with tremor and MLC, yes, but I just think that the work needs to be done. Is it true that essential tremor is asymmetric? Right hand could be much worse than the left. Most definitely.
Absolutely.
Yeah, and in fact, that's what you usually see. And usually its dominant side is worse, but occasionally we see individuals whose non-dominant side is worse. And occasionally we see, you know, individuals who say went through schooling that would have forced their, you know, left hand, where they might have written with their left hand, they'd force the individual to write with their right hand, but they're really left side dominant. And the tremor is actually much worse on that side. But I think too that the other interesting thing about clinical presentation is just how severe rest tremor can be and how much artifact you can get on that planning MR because individuals have
Tremor.
accident tremor. Yeah. And also it's, we talk, we still treat tremor in the head frame, but I think that A, you have to have a really good mask, and then B, I think that a secondary check outside of a frame, like some of the surface guidance systems now with the mask are, I think yielding the level of reassurance that potentially, is equivalent to the fixed head frame. But what are the indications for functional radiosurgery in your institution? Well, severe medically refractory essential tremor is probably the #1 indication for treatment of essential tremor. Dr. Belusic and I have a list of pain syndromes and unusual conditions like hemifacial spasm. We've had a run on hemifacial spasm lately. And we, I think, are, very fortunate and unique to enjoy this very special practice that we have. Can we compare? Can we compare Gamma Knife method and LINAC-based radiation treatment results? Well, of course, there's no head-to-head comparison. I think that at ISRS next week, there's a series that will be presented from the group in Alabama, looking at about 30 patients treated on the Varian LINAC. And I think that there are, a number of series and a number of individuals who have done quite a few of these treatments, but really, I think that the more data is better. Other than Gamma Knife, any experience with ZapX for thalamotomy? No, but yeah, definitely an interesting platform. Thanks for the informative replies. You're welcome. It's really a pleasure to, meet in this format. Yeah, ZapX is all frameless. Yep, we know John Adler well, and we appreciate frameless treatments very much. Most of what we do is in a mask nowadays, but for tremor, we still do use the traditional head frame approach. For 135 gray treatment, for 135 gray treatment, time will be higher. So in between re-image verification when needed, as patient might move. Well, the way Dr. Belusic puts on the head frame, we have a secondary check, which is literally a traditional torque wrench. And I don't know how the pins are torqued, but our physicist does a secondary check on pin torque before the patient goes in the machine. And we are extremely reassured that the patient will not move. They can sneeze, cough, scratch their nose. Dr. Belusic, would you say we have zero concern about the patient moving?
Yeah, in my entire Gamma Knife career, I've had one patient whose head slipped out of the frame in between shots. It was, I think, a metastasis case. So,
the last question is: have you done bilateral tremors at the same time? And the answer is no. And I would make a statement that no one should do this because I think that given the fact that complications are late, that doing this as a staged function, a staged approach, really until more data and very very clear guidelines are established for such a protocol. I think that in select patients, we'll do a staged thalamotomy where we wait, approximately at least 18 months following the first side to be sure that they don't have any kind of A, hemorrhage, or B, late radionecrosis. But I think that in somebody who, if you went forward and you did bilateral, that the complications could be extremely severe in a significant number of patients. So we will not do bilateral at the same time. And
Correct.
I think, Joanne, I think talk number 4 would be, appropriate screening and selection of patients for a contralateral thalamotomy in the setting of prior thalamotomy.
Yes.
It's really, it's a whole nother discussion. And that's our last question. We're, really kind of right on time here. We were slated to go to 10 and it's 10:06. I really appreciate the audience, the interest and the questions, and our presenters, Peter and Sophia today. It doesn't look like anyone has any more questions at this point. So Sophia, Peter, any other comments?
Not that I'm not coming to mind.
Great. Well,
So-
this was actually a lot of
Great
fun.
opportunity to talk in a forum like this. It's nice.
Great, thank you so much. We
Joanne and Carrie,
appreciate-
thanks so much, for hosting, and it was a great format. We really appreciate the opportunity.
Thank you so much for moderating, and as well as to the speakers and to the audience for such great questions and for great future topics for webinars. We will be looking into that. But just to wrap things up, for those that are attending and interested in getting their continuing medical education credits, look for an email in your inbox. We'll have details so you could obtain your CME certificates. And we'll just give an announcement for our next 2 webinars. We have one coming up on Friday, May 17th at noon Eastern Time. It's organized for residents, by residents, but everyone is welcome to attend. And it's going to be on SBRT and immunotherapy for non-small cell lung cancer. Go to the www.therss.org for registration information and details. And then our 3rd webinar in May is scheduled for May 23rd. That's a Thursday at noon. And the title is Adaptive Radiosurgery, Staying in Sync with Shrinking Tumors and Shifting Brains. So again, thank you to our moderators and speakers and our attendees. We appreciate your support and we look to see you at our next webinar. Thank you very much and have a great day.
Thanks.
Thank you.